Intrapartum complications. We're going to cover some of the more common complications and complications that we can do something about intrapartumly in real time. And then we're going to go into even additional complications in class. But we're going to hit the high points right now for things that most require interventions. So these are emergency situations. All of these require prompt intervention to ensure best outcome. We have other complications that we're going to talk about in class that are less emergent. These are your emergent complications. So I like to segregate these into three categories in my head. Okay. So your first category is the cord prolapse, shoulder dystocia, and non-reassuring fetal status. These are mostly problems for baby that we don't really see systemic problems in mom, but we're going to see these for baby. And then the second category, maternal postpartum hemorrhage and amniotic fluid embolism, are mostly problematic for mom and then may systemically affect baby. The third category, uterine rupture and placental abruption, typically affect both mom and baby simultaneously during the intrapartum period. Regardless of who they affect and to what degree, all of these are emergencies that we have to be aware of, assess for, know the risks of, and how to intervene appropriately and in what amount of time to give us the best outcome for mom and baby. So the first we're going to talk about is cord prolapse. You guys are going to become very familiar with this because you'll do a simulation if you haven't already. So this is where the umbilical cord drops through the cervix before the fetal presenting part, which most often is the head, because if we're doing vaginal delivery, head down is preferred, but it could be a different part. The pressure by the presenting part onto that umbilical cord occludes the blood flow and oxygenation to baby. This usually results in a severe variable deceleration seen on your fetal heart rate monitor. To diagnose a cord prolapse, you do this by vaginal examination, palpating for the cord. Now, sometimes, as you can see in the picture, the cord is through the external cervical os, possibly into the vagina, possibly outside the vaginal opening. Or we have the possibility that we might have an occult cord prolapse, which is the left side of the picture, where the cord is slipped down between baby's head and the cervix, or very close to the baby's head and the cervix, but not necessarily out to where you could just see. So vaginal examination is always required to diagnose or rule out a cord prolapse. If a cord prolapse is diagnosed, we use the examiner's hand to press pressure of the fetal part off of the umbilical cord, being very careful to not touch the cord as much as possible, and being careful that the pressure we're placing most likely on baby's head is more on the skull bones and not those soft fontanelles or sutures. The identified route of delivery in the event of cord prolapse is an emergency C-section as soon as possible. Every minute that this is occurring is decreased blood flow and oxygenation to baby, and oxygenation is brain function. So the faster we get this baby delivered, the better our outcomes are going to be. The next complication is shoulder dystocia. You're also going to do a simulation on this complication. What happens in a shoulder dystocia is the anterior shoulder of baby gets stuck on mom's pubic bone. This is most often occurring with an LGA baby, so bigger babies, which means our risk factors for shoulder dystocia include moms who have diabetes, obese moms because they typically have larger babies, grand multiparity, or a mom that has had a shoulder dystocia before. So while the baby is stuck, this is after the head is delivered, that the shoulder gets stuck. After the baby's stuck, we have a decrease in oxygenation to baby. So the longer the dystocia occurs, the worse outcomes for babies are. We have a number of different interventions that we can do to try to release the stuck shoulder. Sometimes the very first intervention releases it and it comes out. Sometimes we make it all the way through the line. It's not a one-size-fits-all approach. So McRoberts is superflexion of the legs, essentially putting mom's knees as close to her ears as we can get them. This opens up the pelvic outlet as much as it will possibly go. Suprapubic pressure is usually the nurse putting pressure using the heel of their hand right over top of mom's pubic bone, ideally pushing on that shoulder that is stuck to get it to pop out underneath this pubic symphysis. The provider can do things called internal rotation, where they try to turn baby to get that shoulder unstuck, or sometimes they can deliver the posterior shoulder first, giving more room to deliver that anterior shoulder. It is a possibility that we purposely, the provider, not the nurse, would purposely break baby's clavicle to get baby out. That is not obviously our first choice of intervention. Then there are some other interventions we're going to discuss in class. Timing is very important during a shoulder dystocia. Best practice tells us that from the time that the shoulder dystocia is diagnosed to the time baby is out needs to be 5 minutes or less. So if we have a number of different interventions that we want to try to get baby unstuck, we don't want to spend a significantly too long of time on any one intervention before we move on to the next. So out loud, closed loop timing of the team is very important. And we'll talk about that more in class and during simulation. Non-reassuring fetal status. So this is referring to the fetal heart rate monitoring. So fetal tachycardia is concerning. However, it's not as concerning or as bradycardia. Bradycardia is much more ominous in regards to fetal heart rate. Severe repetitive variable decelerations and late decelerations are not good for baby. If those occur for a length of time, it decreases baby's oxygen reserve and leads to acidosis. Intrauterine resuscitation are usually our first interventions to fixing baby's heart rate. Our very last resort is an emergency delivery, usually by C-section. So after we have talked about our fetal heart rate monitoring lecture, you'll have a better understanding of those. And then also we'll understand intrauterine resuscitation. The poison mnemonic is a good tool for helping you to remember what the steps of intrauterine resuscitation are. The P is for position changes. O is to put oxygen on mom. I is for IV fluid bolus. The S is for speck and check, checking for either a dropped umbilical cord or if baby has progressed and is about to be delivered very quickly. The second O is to turn off the oxytocin if it's on, and the N stands for notifying the healthcare provider in the event that you've tried all your nursing interventions and baby's heart rate still isn't up. Maternal postpartum hemorrhage should be review. We have covered postpartum hemorrhage in class. You've had it on a test. You've done it in simulation. So remembering that we usually see excessive bleeding, hypotension, tachycardia, decrease in O2, cramping and pain reported by mom. Our first and foremost intervention is fundal massage, hoping to get that uterus to contract and slow our bleeding. Other interventions include starting a second IV, giving a fluid bolus, laying mom flat or in Trendelenburg, supplemental O2, quantifying that blood loss, and then using our medication management with oxytocin, methergin, Cytotec, Hemobate, and maybe TXA. Amniotic fluid embolism is very big, scary, hairy monster. It does not happen very often. It's actually a very rare complication, but when it does, it has about an 80% mortality rate, which makes it very, very severe. So this is a problem for mom. What happens is there's a small tear in that amniotic membrane, essentially, and a small amount of amniotic fluid leaks into the maternal system under the pressure from labor. So think of it kind of like a pulmonary embolism, but the embolism is made of amniotic fluid, not a blood clot. So it floats from the uterus up through the circulation and into the lungs. Mom often has initial signs and symptoms like a pulmonary embolism. So she's going to have that shortness of breath, onset of respiratory distress, kind of that sense of doom. We might see that initial change in SpO2, but this is more serious than a pulmonary embolism in the way that it leads to hemorrhagic shock via DIC and eventually intubation, cardiogenic shock. All these things kind of happen as sequelae. So it requires very, very immediate supportive interventions in the way of CPR, intubating the patient, managing the DIC symptoms. If this occurs while baby is not delivered, baby needs to come out ASAP. If baby has just been delivered, then it's just a focus on mom. The problem with amniotic fluid embolism is if you look at that second bullet point, the risk factors, that's a really extensive list of risk factors. And that's because it doesn't happen very often, so that it's really hard for us to pinpoint, oh, this is a patient who's going to have this problem. Very, very rare. So just knowing that early identification is important, and then early interventions to support is important, and then we go from there. Uterine rupture looks very frightening in that picture. So what happens is there's a laceration of the uterine wall while baby's still inside. This most often occurs at the site of a C-section scar or prior surgery to the uterus in which the muscle tissue is weaker because of that surgery and that opening, that scar tissue. This is the number one risk with VBAC, so vaginal birth after cesarean. This is why those are more risky than a regular vaginal delivery because of the risk for uterine rupture. It can be not as severe as the picture shows. It can be incomplete, small amounts. It doesn't have to be all the layers of the uterus. Sometimes we catch it way before it gets this bad. Sometimes it's abrupt and severe and looks just like the picture. But mom typically feels pain, and then the sensation, kind of the pain gives way, and we see effects of blood loss both in mom and baby in the way of the fetal heart rate and mom's vitals and signs and symptoms. So this is a big risk with VBAC deliveries. Placental abruption is the early separation of the placenta from the uterine wall. Now, I say early because ideally, once baby's out, we want that placenta to detach and be delivered. But this is the separation while baby is still in utero, whether that's the antepartum period or intrapartum when we're trying to have a baby. Placental abruption is one of those complications that has a really wide range of severity. We can have a very small abruption that is more chronic in nature, doesn't, hugely affect mom and baby. We have this bleeding, we monitor really closely, but we can maintain the pregnancy for a while longer, all the way to catastrophic, complete abruption of the whole placenta, which essentially completely stops blood flow to baby, which is an absolute medical emergency. So any bleeding in pregnancy is not to be assumed normal. So when we do have bleeding, we assess the fetal heart rate, mom's vitals, we quantify the blood loss to give us an objective means of how much that is, and then we formulate a plan of care from there. So much of the intervention and plan depends very greatly on the severity of the abruption. And we'll go more in depth to that in class. So there is a quick overview of some of the complications that you're going to be responsible for understanding in the intrapartum period.